Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching video class. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, we are going to discuss one more set of 10 MCQs on choledocholithiasis, one of the important cause for obstructive jaundice. So again, I need not emphasize the importance of MCQ. All exams, your qualifying exam or your competitive medical entrance exams like NEET PG, NEET SS, FMGE, USMLE, UKMLA. So everywhere they are using only MCQ to judge you, okay, to evaluate you. So that is why MCQ is very important method of assessment of the students. So you must know how to deal with MCQ exam. This series of MCQ videos will give you a systematic way of revising the whole spectrum of general surgery, topic by topic. So it is the best way to read, to prepare for the MCQ exam. But before going to discuss those 10 MCQs, I want you to watch this video first, this particular video on choledocholithiasis, by clicking this link. Go and watch the video now and then come back. Let us discuss the 10 MCQs. The MCQ number 1, a 45-year-old woman presents with right upper quadrant pain, fever and jaundice. Blood tests reveal elevated ALP and conjugated hyperbilirubinemia. Ultrasound shows a dilated common bile duct but no stones in the gallbladder. What is the most likely diagnosis? A. Hepatitis A. B. Acute cholecystitis. C. Choledocholithiasis. And D. Primary biliary cholangitis. Of course, the correct answer is C. It is choledocholithiasis because the classical Chagas triad, that is fever, right upper quadrant pain, plus jaundice is there, plus the bile duct dilatation is also there, which is suggesting CBD stone obstruction. The common bile duct stones are obstructing. So this is called choledocholithiasis. A is incorrect because hepatitis causes hepatocellular jaundice and usually no cholestasis. B is also incorrect. Cholecystitis does not usually cause jaundice unless secondary to some obstruction. And D is also incorrect. Primary biliary cholangitis is an autoimmune disease and progresses slowly, typically without fever. Reference is 28th edition of Bailey and Love, chapter 65. Coming to MCQ 2, a 52-year-old male with gallstones develops jaundice and itching. Labs show ALP 460 unit per liter and direct bilirubin 8 milligram per deciliter. Ultrasound reveals a dilated CBD of 12 millimeters. What is the next best investigation? A. MRCP. B. CT abdomen. C. Upper G endoscope. D. Serum amylase. Of course, the correct answer is A. MRCP. This is magnetic resonance cholangiopancreatograph. Is a non-invasive and accurately you can visualize the CBD stone. Okay. Among these option, okay, MRCP. Suppose if they have given ERCP also, then that should be the choice. So B is incorrect because CT is less sensitive for stones. C is also incorrect, that is upper G endoscope does not visualize, you won't see the biliary tree if you are doing upper G endoscope. And serum amylase is useful only for pancreatitis and not for ductal stones or choledocholithiasis. Reference the Squad's Principle of Surgery, 11th edition, chapter 38. Coming to MCQ 3, a 58-year-old man presents with sudden onset of jaundice, fever, and right upper quadrant pain. Blood culture is positive for E. coli. USG shows CBD dilatation but no visible stones. What is the best immediate management? A. Start antibiotics and plan elective cholecystectomy. B. ERCP with stone extraction. C. Percutaneous drainage. D. MRI abdomen. Of course, the correct answer is B. ERCP with stone extraction. ERCP is not only diagnostic, it is therapeutic in acute cholangitis due to choledocholithiasis. You can do ERCP and you can remove the stone. A is incorrect. That is because antibiotics and plan elective cholecystectomy, no. ERCP and stone extraction should be done because this delays the definitive treatment. C is also incorrect, that is percutaneous drainage for inaccessible abscess, it is not a primary treatment, percutaneous drainage. And D, MRI abdomen, MRI also against delay urgent decompression. So immediately you have to do ERCP with stone extraction. That is the correct answer. Reference is Sabiston, 21st edition, chapter 52. Coming to MCQ 4, 50-year-old woman with a history of gallstone present with jaundice. CT abdomen shows a dilated CBD and a hyperdense focus in its distal part. What is the most likely cause? A. Gallbladder carcinoma. B. Choledochal cyst. C. Choledocholithiasis. D. Mirices syndrome. Of course, the correct answer is C. Choledocholithiasis. Distal CBD stone appears hyperdense and causes dilatation. And another thing it will produce, it can produce distal stone in the CBD can produce pancreatitis also. So A is incorrect, gallbladder carcinoma. That affects GB first and not CBD. B is also incorrect, choledochal cyst is a congenital problem often diagnosed earlier in the life. And D, mirices is a stone compressing the common hepatic duct from the cystic duct because it is stuck at the level of cystic duct, the stone, and it is going and compressing common hepatic duct, not CBD, and not within the CBD. Yeah, it is from outside, it is compressing common hepatic duct. Reference is Bailey and Love, 28th edition, chapter 65. Coming to MCQ 5, a 40-year-old woman undergoes laparoscopic cholecystectomy. Intraoperative cholangiogram reveals a filling defect in the CBD. What is the best next step? A. Close and observe. B. Perform intraoperative CBD exploration. C. Refer for ERCP post-operatively. D. Convert to open surgery immediately. Of course, the correct answer is B. Perform intraop CBD exploration. Because if CBD stone is found intraoperatively and expertise is available, then go ahead and explore the common bile duct. CBD exploration is preferred. A is incorrect, that is risk of cholangitis if you are just going to close the abdomen and observe. C is also incorrect. C is refer for ERCP post-operatively. No, that is incorrect because acceptable offer alternative if no facility is available. Okay. D, convert to open surgery immediately. Open conversion is not required unless laparoscopy fails. Reference is again Sebastian 21st edition and biliary surgery. Coming to MCQ 6, a patient with CBD stone present with elevated bilirubin, ALP, and amylase. What complication is likely? A. Acute hepatitis. B. Chronic pancreatitis. C. Acute biliary pancreatitis. And D. Gallbladder carcinoma. Of course, the correct answer is C. Acute pancreatitis. Explanation: CBD stones can transiently obstruct the ampulla of Wetter, leading to pancreatitis. Because of this block, the bile won't flow into the duodenum. Instead, the stagnant bile will get reflexed back into the pancreatic duct, and this will excite the pancreas, and pancreas will go for acute pancreatitis because of the reflex of the bile back into the pancreatic duct. That is the cause. A is incorrect. Acute hepatitis. You would have, if it is hepatitis, there must be elevated ALT and AST. B is chronic pancreatitis is also, it is a chronic disease present differently, not like this. This is acute pancreatitis. Chronic pancreatitis will present totally different. What it will have very severe pain, of course. It is there in acute pancreatitis also, but patients will have both endocrine and exocrine deficiency. Namely, they will be having diabetes mellitus as well as steatorrhea. Okay, and D is also incorrect. Gallbladder carcinoma is unrelated to amylase rise. Amylase won't be elevated in gallbladder CA. The reference is Swartz Surgery 11th edition, chapter 38. Coming to MCQ number 7, a 65-year-old man with a known CBD stone is unfit for surgery. What is the best treatment option? A. Laparoscopic cholecystectomy. B. Percutaneous stone removal. C. ERCP with sphincterotomy. D. Medical dissolution therapy. Correct answer is you have to do ERCP with sphincterotomy and then you have to remove the stone. Explanation: ERCP with sphincterotomy and stone removal is preferred in high-risk surgical patients. A is incorrect. Laparoscopic cholecystectomy not suitable in unfit patients. B. Percutaneous stone removal technically complex and it is not the first line also. D is also incorrect. Medical dissolution therapy is ineffective for CBD stone. Coming to MCQ 8, which of the following is the most common organism isolated in cholangitis due to choledocholithiasis? A. Streptococcus. B. Klebsiella. C. Escherichia coli or E. coli. D. Pseudomonas. Of course, the correct answer is C. E. coli. Explanation: E. coli is the most frequent gram-negative organism isolated in ascending cholangitis. All other choices A, B, and D can occur but less common. Reference: Mendel's infectious disease, 9th edition. Coming to MCQ number 9. Which lab pattern suggests obstructive jaundice from choledocholithiasis? High unconjugated bilirubin, normal ALP, no. Elevated AST ALT, low GGT. high conjugated bilirubin, high ALP and GGT. Yeah, this is the correct. Normal bilirubin D, elevated LGH. The correct answer I told you C. Okay, explanation. The classic cholestatic pattern seen in CBD is high conjugated bilirubin, high ALP and GGT. Both ALP and GGT should be raised. Otherwise, if ALP alone is elevated, it could be some other cause. So D is also incorrect. LDH is not a liver specific enzyme. Okay, this is not in this, it's unrelated. Reference Davidson's 24th edition. Coming to the last question, MCQ 10. Which of the following imaging modalities is most sensitive for detecting small CBD stone? Brain abdominal X-ray, ultrasound, CT scan, MRCP. Of course, the correct answer is D, MRCP. MRCP provides high resolution, non-invasive imaging of biliary ducts and is superior for small stones. A is incorrect because CBD stones are rarely radio opaque. If you are taking a plain abdominal X-ray, you cannot visualize. B is also incorrect. Limited for distal CBD visualization. Ultrasound is ineffective. CT scan also less sensitive. So the correct answer is MRCP. Reference again Sebastian's textbook of surgery, 21st edition. So these are the reference I am giving in all my videos. The Hand and Muscle and Clinical Surgery by Mohan D. Silva. These two books are problem-oriented books. Only very few books are there in the literature. And then all other books, 100 cases, case files, clinical scenarios, surgery, a case-based clinical review, everything is case-based discussion will be there in each and every book. All these case scenarios you can go read and practice. Click this link to watch what are the latest textbooks you need to become a competent or master surgeon. To making of a surgeon very effective, you need all these books on general surgery. So this is my own book. I have created case-based discussion. So this is clinical case discussion. 9 modules are there. You can click this first link to download the book itself, or you can click the second link so that you can watch the playlist of all the 9 modules in this book. So you can do either this, that, or this. You can read the book or you can watch my video and learn. So thank you very much for watching this video. If you think that all my videos are very effective and helpful, kindly share them in your social media. Kindly press the bell button also to get notified regarding my latest uploads. Let us meet in yet another episode. Until then, bye bye.